Good morning, everybody, and welcome to the seminar series we run for the Center for Global Health Science and Security. Really very delighted today. We have a lot to get into, so I'm going to make my introductions extraordinarily short, but delighted today to have with us Dr. Anjali Ashokar, who is currently the acting U.S. Global AIDS Coordinator. She's officially the Principal Deputy U.S. Global AIDS Coordinator, which is a Principal Deputy Assistant Secretary position. Anjali's been working in PEPFAR since, I believe, 2003, and so has been with this program since the very beginning, at all the different parts of the U.S. government that work on this. So she is truly a wealth of knowledge in kind of the history of the program, as well as how it's evolved over time. And so delighted that she was willing to be with us today. Now, before I turn it over to Anjali, I also want to briefly introduce my colleague, Deus Becerra. Deus is the director of, and let me make sure I get the name of his center right, the Center for Global Health Practice and Impact, which is another center in the medical center here at Georgetown. And Deus and his team have been working on PEPFAR, mostly in sub-Saharan Africa, as well as in the Americas. And so I have asked Deus, and he was willing to wake up early this morning as well, to help moderate the conversation. So what's happened is Anjali will speak for a little bit, and then Deus will moderate Q&A. And we ask that if you have questions, that we use that Q&A function in Zoom. So with that, I'm going to turn over to Anjali. And again, thank you so much for doing this with us this morning.
Great. Well, thank you so much, Rebecca, and thanks to Georgetown, and thanks to all of you for joining this morning. I'm really excited to be here. I'm going to let me share my slides, make sure that everyone can see. So I'm really, really pleased to be here to talk to you about saving lives and transforming health systems, and to give you some perspective from PEPFAR's past, present, and future. And as Rebecca said, I have been so privileged to be a part of PEPFAR, which is the President's Emergency Plan for AIDS Relief, since it started in 2003. And I've seen it through since its various iterations and to where we are now, basically combating two pandemics at once, HIV and COVID-19. So with that, I'll dive right in. So I thought it's always important to ground ourselves in where we were, where the world was before PEPFAR was even born. At that time, at the height of the HIV pandemic in the late 90s, nearly 30 million people were living with HIV, and there were about 10,000 new HIV infections every single day around the globe. At that time, 20 to 30% of adults were infected with HIV and dying in the highest burden countries. When you have a state where, it's a fragile state, when you have 20 to 30% of adults dying, these are teachers, mothers, fathers, doctors, where life expectancy declines were over 20 years in high burden countries, the working age population was being devastated. You know, this was a true catastrophe. At that time, child-led households were the norm. You know, children were orphaned. At that time, less than 1 million people were on life-saving treatment, and less than 50,000 were on life-saving treatment in sub-Saharan Africa. Health systems everywhere were overwhelmed by the pandemic. You know, you could see people just, coffins were one of the big industries at that time. And so where we are now, the US responded in a very big way to respond to global HIV and AIDS through PEPFAR. PEPFAR is and continues to be the single largest health and health system program ever that the US government has ever funded. Over $85 billion. It is now in 55 countries. It was launched in 2003 by President George W. Bush and continues with strong bipartisan leadership from President Obama to President Trump, and definitely continues with President Biden. What it is a novel approach and a model to foreign assistance that's built on focus, data, and performance. It involves the entire US government in its implementation. And right now, we're saving millions of lives with comprehensive HIV prevention and treatment services, but also we've been building critical health systems and capacities all the while. And I'll talk about this and how it both impacts and relates to HIV, but also broader health threats. And what's most exciting is that for the first time in modern history, we're controlling HIV without a vaccine or cure. It's unprecedented. So as I noted earlier, PEPFAR has really enjoyed complete, unwavering bipartisan congressional and presidential leadership over the years. And it has continued and is even more pronounced with this administration, which we're so very grateful for. We have aligned our investments to the HIV burden. So what you can see on this graph is the darker the blue, the greater the HIV prevalence, and the larger the country, the greater the burden of disease. So you can see in South Africa, and these data are slightly dated, but you can see our investment is really tracking to where the burden of HIV is. So you can see South Africa, for example, Eswatini, Lesotho, with greater investment. So we're really pleased to say that where we are, this is as of fiscal year Q3, we will release our latest results on World AIDS Day, which is December 1st. But the latest we're sharing at this point is that we have 18.4 million people on life-saving treatment. Again, we started before PEPFAR with less than 1 million people on treatment. So it's incredible to see where we are now. We have 27.4 million circumcisions that have been administered to prevent HIV infection among young men. We continue to make great strides in our work with orphans and vulnerable children, as well as HIV prevention with adolescent girls and young women. But I think what's important to note is really how challenging it has been through COVID-19. And so a lot of my talk will really focus on how we've been maneuvering, adapting the program, the HIV program, in the midst of COVID-19. When COVID really hit, we within PEPFAR started to immediately respond. In early March of 2020, even before that, late February 2020, we began to adapt the program in real time to really do everything that we could to protect the HIV gains while we were hoping to help respond to COVID-19. And just a snapshot of what we've seen, and I'll go into the data, is that PEPFAR demonstrated resilience in the face of COVID-19. We preserved our treatment, and that actually increased. Our HIV testing and some prevention services like circumcision and some of the prevention services for adolescent girls and young women dipped intentionally during COVID-19, but we've seen that rebound and is now back on track and increasing again. And then what we've also seen are some services that scaled rapidly, such as self-testing, pre-exposure prophylaxis, multi-month dispensing. These are things that we've learned that through COVID-19, the people that we serve prefer different types of services being administered to them in different ways. And so these are things we are institutionalizing in the program. We have leveraged health systems strategically, like I said, to respond to HIV and COVID-19. But the final point is COVID-19 continues to persist. Vaccine coverage is very low across the globe. And so we're having to continue to adapt the program to preserve our gains. So essentially, like I said, in early March of 2020, we released guidance, and we have continued to release guidance on a weekly basis that allows the program to shift, to adapt, to change as needed to work in the context of COVID-19. And what I'll do now is talk about some of those significant adaptations that have both preserved our HIV services and protected the populations most at risk of COVID-19 as well. So some of the things that really were extraordinary during COVID-19 that the PEPFAR program pivoted and adapted toward were maximizing continuity of treatment before lockdown, We tracked our clients. We used virtual platforms to really stay in touch. Multi-month dispensing of ARVs was absolutely critical. We wanted to make sure that the clients were not going into the stable clients were not going into the facility as often as they had to, because there was risk of exposure to COVID-19. So we really moved, and this is something we've been doing for a number of years, but it really wasn't until COVID that country governments picked up these policies to ensure that the provision of 3 and 6 months of drugs were available to the clients. We brought drugs closer to the community and closer to the homes of where the clients live. So decentralized our drug delivery as far as we could into the communities. We used virtual platforms, telemedicine, other ways to deliver services to make sure that we weren't convening in person that would then, potentially put clients at risk. And then we empowered communities. Communities have been central. Local partners and communities have been central to our work. This slide really shows a couple of things, but really that we are maintaining our HIV treatment continuity that you can see in the red dotted graph. And this is through the context of COVID-19, where you can see the peaks and valleys from a number of countries of COVID-19 daily cases per 1,000. This graph shows the rapid increase in the percent of people living with HIV on ART that are receiving multi-months of ARV. So on the left, this is pre-COVID 2020 Q1, where you can see less gray and blue, which really signifies greater months of multi-month dispensing, where you can see in 2021 Q3 much more gray and blue, which signifies the direction we want to be going. This is some of our data with circumcision. So you could see the impact of COVID-19 in fiscal year 20 Q3, where COVID-19 really impacted the program. But what's encouraging is what you can see with our latest data, fiscal year 21 Q3, where we are back at about 70% achievement towards our annual targets, which is comparable to where we were in fiscal year 19 and fiscal year 18 at the same quarter. So again, we're rebounding with our circumcision, which is great. Prevention services. So this is a little more, but focused on adolescent girls and young women. So you could see on the left, our prevention services really dipped with COVID-19. As I mentioned earlier, we weren't able to administer prevention services in the way that we had been previous to COVID-19. But you can now see with Q2 2021 that our services have picked up again. And in large part, that's because the delivery of the group-based prevention activities have shifted to virtual platforms and other ways of delivering those services. And then you can see PrEP, pre-exposure prophylaxis. You can see the increase, again, signifying that this is something that adolescent girls and young women are really desiring, particularly in the wake of COVID-19. And so this is something we're scaling up. So what's interesting and relevant to this conversation in this series is when we look at the PEPFAR platform. And what do we mean by that? PEPFAR offers a care delivery platform for HIV and COVID-19. And that is really, while we have been authorized and appropriated as an HIV program. So we focus on delivering HIV prevention and treatment services. We've had to, over the past 18 years, we've had to develop and strengthen local capacities, whether it's lab systems, surveillance systems, supply chain systems, the healthcare workforce, doctors, nurses. These systems and infrastructures have had to be strengthened for the delivery of HIV services, but they have been utilized and leveraged for other health diseases, including COVID-19. And that's what's most compelling. So Since the beginning of PEPFAR, we have invested over $15 billion in the health system. And these, include things like laboratories, lab networks. We're in 70,000 healthcare facilities. We've improved those healthcare facilities, the infrastructure there, but also have granular data and access to people at all of the 70,000 healthcare facilities around the globe. We have increased new healthcare workers on the order of about 300,000. These include community health workers, public health workers, laboratorians, nurses, doctors, counselors, and then we have improved commodity supply chain. All of these were set for HIV, but again, have greater utility. And we've been proactively leveraging this platform to support COVID-19. So since March of 2020, what we've been doing is utilizing that health system together with country governments and the communities to do everything from COVID-19 screening to diagnostics, infection prevention and control, vaccine readiness, dealing with hesitancy, and now we're also getting vaccines into arms. So we're administering COVID-19 vaccines as well. It's always great to give a few country examples of how this is translating. And so I have a few here to share. This is PEPFAR Nigeria, and this is what they've been doing to integrate COVID-19 testing into the viral load and early infant diagnosis lab networks. And so that's an example in Nigeria. In South Africa, they have been supporting, well, they've been doing a lot, but this is just an example of how they've been supporting key mitigation effects of the fourth wave by really working on the COVID-19 vaccine support. So as the US has been donating incredible amounts of vaccine into these countries, we've been then leveraging the PEPFAR platform to figure out how we can work with the government to both do everything from, again, helping to get the vaccines through the systems and then ultimately into the arms. But we're doing everything from procurement of equipment, PPE, vaccine consumables, but also data systems that are including GIS mapping hotspots to make sure that we can move the vaccines as they need to be, but then utilizing the healthcare workforce as well that we support with HIV to help get vaccines into arms. Zambia, this is one of my favorite examples. This is COVID-19 vaccination in ART clinics. So one of the things that we've seen happen in Zambia is in the high volume sites where we're working on HIV in Lusaka, in the very first week where we started to work on these synergies between HIV and COVID-19 vaccination, we were able to vaccinate 1,000 people living with HIV in the first week. We've been working then with refusal rates, supporting healthcare workers to answer questions about vaccines. The government was so impressed by the fact that in 3 weeks then, we scaled up to 7,000 people living with HIV being vaccinated, including additional family members and escorts that came to the clinic with them. So it just scaled up tremendously that now the Ministry of Health has issued a circular to expand this practice across all 10 provinces in Zambia. This, I think, is an example of the opportunity and the possibility of bringing these efforts together in a really impactful way so that it is both benefiting people living with HIV, but broader communities by leveraging the trusted systems that are on the ground, the people that have the know-how to do this, and the relationships that we have with governments and the community to make this happen. I wanted to talk a little bit about, I'm shifting gears a bit, but wanting to talk a little bit about the financial impact of COVID-19 on some of the countries in which we work. So this graph shows the projected gross domestic product growth versus HIV prevalence in a number of countries across across Africa. And what we see here that is not news to any of you is that economic problems from COVID across the board persist, but that they're worse in countries with high HIV prevalence, as you can see on the rightmost part of the graph here. This is very concerning to us as we think about the work ahead of us for HIV, as well as the continued impact that COVID will have on our services. Here we show HIV investments by funder in PEPFAR supported countries. So for example, here in red, you can see the percent that is PEPFAR in each of these countries. In blue, the percent that is Global Fund. Again, the US is a third of the contributor to the Global Fund. And then in gray, the domestic government. And so again, as we think about the impact, the economic impact of COVID-19 on the countries and the work that we're doing with HIV and the shared investment, these are things that we have to look at very closely because there will be hydraulics that will be happening. It is a difficult space that we're all in. One of the things that is critical, I mentioned this earlier, but I want to emphasize this again, is how important local and community partners have been in the work that we do with PEPFAR. We believe that sustaining delivery of HIV services is absolutely critical with local and community partners. And what we've seen through COVID-19 in particular is that it is the local partners that have been on the ground and have continued to be on the ground through COVID-19, still serving the PEPFAR beneficiaries. On this slide, you see in this current fiscal year, the amount of funding, PEPFAR funding that we have going to local partners in red and international partners in blue. And so we have set bold goals for 70% of all of our funding to go to local partners. And so that's what we're striving to achieve. And you can see it varies where in certain countries toward the top, like Rwanda, Kenya, South Africa, some of these other countries, that over 70% of funds are going to local partners, where we still have a lot more work to do as you look at the bottom part of the graph here. I would be remiss if I didn't talk about the American Rescue Plan Act of 2021. This has been an extraordinary endeavor this year, where our Congress and the Biden-Harris administration has really supported intensive investment and efforts to respond to COVID-19. Here I'll talk about the $250 million that was appropriated through the American Rescue Plan Act to the PEPFAR bilateral program. And what we've done is we're implementing this right now, but what we've done is utilize it in 3 ways: to address some urgent ARV commodities needs due to COVID-19, to prevent, prepare for, and respond to COVID-19, impacts on beneficiaries. That's a lot of the systems work that we've been doing. And then some real targeted efforts to mitigate and repair some of the injuries we've had to the program. In the pie chart, you can see how our investments are tracking to various categories, whether it's vaccination efforts or COVID-19 efforts or mitigating some of the impact of HIV or COVID on HIV. And then the largest contribution that we are making as a US government is to the Global Fund to fight TB, to fight AIDS, TB, and malaria, where the Congress appropriated $3.5 billion to the United States for the United States contribution to the Global Fund. And this has been utilized, and we've been working with the Global Fund over the almost now 2 years to make sure that they could effectively respond to COVID-19 as well. And they've been just as effective as we have been through the PEPFAR platform. So we're getting to a point which is pretty remarkable, that countries are beginning to really achieve their global 95-95-95 targets across countries. This is the UNAIDS targets that all countries have signed on to, which effectively is that 95% of people living with HIV are aware of their HIV status, and then 95% of those that are aware of their HIV status are on treatment. And then those that are on treatment, 95% of those are virally suppressed. What we want is viral suppression at the community level. And we're seeing that country after country, we are seeing countries that are getting to a state of epidemic control, which is, again, extraordinary because we do not have a vaccine or a cure for HIV yet. But what this is a testament of is the remarkable treatment and prevention solutions that are being brought to bear in a very targeted and focused manner to stop the spread of transmission of HIV. And so here's a snapshot of countries that are at epidemic control of HIV when we look at their epidemic curves. I won't go through all these countries, but we have a number of countries that are at epidemic control of HIV. We have another set of countries that are nearing epidemic control of HIV. And then we have a set of countries that are declining in new infections, but not yet at a state of epidemic control of HIV. And so, you know, our services and our approaches are tailored to where each of these countries are. And then the question becomes, when countries get to a state of epidemic control, how do we sustain epidemic control of HIV? And what does that look like? And so what is presented here are a number of elements that are critical to ensuring a sustained response to HIV, where equitable health services and solutions can be in place to sustain epidemic control of HIV. It will require a whole of domestic approach, government and community. It'll require enabling policies and programmatic environments that are in place, sufficient technical and managerial capacity to maintain these programs, and then resource these programs, so financially sustaining essential services. It'll require HIV services integrated into the broader public and private delivery systems, and then robust surveillance, public health response to monitor and track not just outbreaks of HIV, but the same surveillance that is required that will be needed for other health threats as well. And then quality assurance. We have to ensure that we're effectively managing and monitoring quality of services. We do have some challenges with particular populations as we look at sustaining epidemic control of HIV. We continue to have challenges with adolescent girls and young women, with key populations, including LGBTQI+ populations and children. And of course, COVID continues to rage. And so these are things that we are doubling down on, these populations and ways in which we're serving these populations, addressing barriers to access of services. But there is an opportunity, there's an opportunity to really make sure we can tackle some of these inequities by working better across sectors. We can target some of our efforts even more to these specific populations. It's really critical to look at age and sex disaggregated data and subnational data so that we can really pinpoint where the gaps are and focus resources there. And then we need to continue to leverage these platforms that are in place. We've shown that we've been able to maintain HIV services in the wake of COVID-19, but also utilize these platforms to respond to COVID-19 effectively. That's an extraordinary story, and I think a smart investment for the US government and the globe. So this is something we can look to do for the future even further. This is my last slide, and I'll stop with kind of where we're seeking to go in the next 5 years. We have been working on a PEPFAR strategy for 2021 through 2025. This tracks with the UNAIDS strategy, the Global Fund strategy, and kind of where the globe is headed as it relates to sustainable development goals for 2030 and where we all need to go. And so essentially where we are going is to sustain epidemic control of HIV with these three overarching goals. Number one, accomplishing the mission achieving and sustaining epidemic control with equitable people-centered services. Second, building and durable capabilities. So this is all about the resilient and capacitated country health systems, enabling environments and local partners. And finally, we can't do this alone. This is about lasting collaborations, strengthening our coordination across sectors, across multilateral partners, across public and private sectors, and with the community to really ensure greater impact, burden sharing, and sustainability. So I'll stop there and turn it back over to you, Rebecca and Deus, but I'll just stop with a thank you.
Thank you, Anjali. I believe for some of us who have been in PEPFAR, or working on PEPFAR-related interventions for the last 17 or 18 years, we needed this kind of refresher course. So I'm sure even for those who have not engaged with PEPFAR, they will walk away today with at least a better understanding of the remarkable work that PEPFAR and of course the US government has done to turn the tide against this global pandemic that at one time was threatening to wipe out populations in certain countries. So I'm not going to take up a lot of time as a moderator. My job is to, let the audience ask you questions. I'm sure there is a lot people would like to know more about what you're doing, especially when it comes to issues of sustaining these gains that have been made over the last 18 years. But before we get into that, I'll just briefly reflect on my own experiences and some of the things that I hear from key stakeholders, especially in countries where PEPFAR has been very helpful over the last 17, 18 years. So there's never been a time in history when, well, maybe 100 years ago, when public health became mainstream. What I mean by this is there's no country or any meeting you go to, or even on the streets, in hotels, in restaurants, where people are not talking about public health now because of the COVID-19 pandemic. So in a way that has provided an opportunity and, for us as public health practitioners to, to gain the attention of the people that we've always labored hard to reach, especially policymakers, but we're never very successful. I'll just give you a brief example. I just came back from Eswatini, a country you know very well, that has been one of those that at least is on the cusp or has achieved some of those key UNAIDS goals. And what we learned during that trip was, first and foremost, there is this sense of urgency and worry from the country that some of these gains that have been made, especially on the HIV front, could be reversed because of the COVID-19 pandemic. However, at the same time, there is a lot of excitement and it's palpable. You could feel it. The country believes that if we leveraged what PEPFAR has done and the other bilateral and multilateral agencies that have supported HIV response, there is a real opportunity here to really, really strengthen health systems, and particularly to revamp primary care as it should have been, because the HIV delivery platform is a true primary care platform, the way we all envisaged primary care would look like. However, they have some few issues or concerns they raise. One is that the PEPFAR platform in particular remains resource intensive, in their country, and we've had this from other countries. And so they worry that even though PEPFAR is delivering all these outcomes, if those resources were not available at the level they currently are, and the structures and systems that have been built using PEPFAR and Global Fund resources, for example, then the countries could struggle to sustain the gains that have been made. I know, based on your talk, that you are also thinking about these issues at OGAC. You're working on a new strategy to address some of these sustainability issues. But what should we expect to see on a day-to-day basis when it comes to the design of PEPFAR-supported programs? What type of changes should we expect to see that really try to respond to some of these concerns? In other words, trying to look at at how resources get invested to sustain these gains in a way that does not make it too expensive for countries to ever sustain. And what would be the meaningful day-to-day changes we also see in the next 5 years that are different from the last 13 or so years. And as you speak to these issues, you may want to shed more light on things like supply chain and the question of integration, technology systems, because this integration question has been part of PEPFAR for a long time. But the reality, when you go, I think prior to COVID, HIV service delivery remains largely, operated through a vertical approach as HIV service. We haven't seen a lot of other things brought in, or HIV hasn't gone into the other services where we could achieve true integration and realize some efficiency. So I'll stop here, give you an opportunity to make a few comments on that, and then I'll turn it over to our participants to ask questions. Thank you.
Terrific. Thanks so much, Deus. And, I so appreciate hearing your recent reflections from Eswatini. But I'll start with where you started, which was talking about public health. You said public health is mainstreamed, or was, we haven't seen that. And I thought that was so compelling because it is true. I mean, we're finally, with COVID, the whole world now understands and knows what public health is. But HIV, it's something we've been doing for so long, for decades, for 40 decades, and we've been, just as intensely working on public health, but it hasn't been something that the entire world has seen, but the impact of it is extraordinary. So some of your questions, or your reflections coming back from Eswatini and some of the fears that you expressed, the opportunity and the fears that you expressed that the team on the ground was having, whether it's, the real opportunity to continue to leverage some of these systems, but also fear of, that these gains could be reversed. As we think about the future, as we think about, sustaining these gains and how this could look for the future, there are a couple of very specific things that we're working on right now within PEPFAR that'll help us get to a better place so that these resources that are required to sustain epidemic control of HIV can be realized in the future. First, we are working on what we call ABC, which is activity-based costing. We are really trying to understand not what have we paid for a service, but what does it truly cost for a service? And that's a big there is a big difference between the two. And so that's something that we're really digging into to understand, what does it really cost? Because that's what's going to be essential as it relates to financially supporting the costs of these services into the future. The other thing that we're doing, and I mentioned this in my slides, we've been actively pushing toward local service delivery by local partners. There's two reasons for that. One, it makes more sense in terms of the local partners themselves that are in those countries or representing the populations that we're serving, understanding what the real needs are. But two, it's important for sustainability. It is fundamental for sustainability to make sure that the capacity exists in the countries, in the communities to deliver those services. So what we have found over time, because we've been working on transitioning services to local partners for a long time now, but what we've been learning and what we've been able to show with data is that the performance of local partners is on par, if not higher, than that of international partners. That is a huge success story. And what that shows us is that, number one, the capacities in countries have been improving over time. They have the ability to to perform these services, like I said, on par, if not better, than international partners. There are tremendous cost savings in with local delivery than with working with international partners. Now, it's never going to be a situation where we move everything to local service delivery. There are, certain services that will require support and technical assistance from international implementing partners as well. But this is a direction we're going. And the third thing, actually, there's four. The third is simplification. We are, and this is something COVID has taught us too. We need to simplify our services for what makes sense for the people we serve. We need to get closer to where they are in the communities, and we need to figure out how we are removing burden, removing extra, like I said, going into the facility. There's no need to go into the facility as often when we can decentralize the drugs closer to the home. So these are things that we're learning where we have to figure out how we simplify even further, because there will be cost savings there, but it'll also be better for the clients, the people that we're serving. And the fourth is probably the most important thing. And this is what you were referring to, Deos, and that is integrating services. Now, what we've often thought of and what we've been attempting to do is trying to create like dual purpose systems, if you will, like lab. This is why I was giving you the example of the COVID-19 diagnostic on the viral load PCR. There's slight adaptations that need to be made, but if we went in with the intentionality of multi-purpose or dual purpose systems, or that our trainings of healthcare workers, for example, are multi-purpose versus just HIV, will have a greater impact for HIV, but also for other services. So we're actively seeking ways to integrate HIV into broader services, and vice versa. Wherever there's the moment to integrate, we're looking to do so. The bottom line is people are people. We can't silo people, right? It's the same people that we are serving that have HIV, that are also getting infected with TB, that are also getting infected with STIs, that are also getting infected with COVID-19, et cetera. And so, these are ways that we're trying to think about this with real intention to deliberately integrate services so that it is more person-centered around the whole person versus the program that we have. So I'll just stop there with some immediate reflections to your comments.
Thank you so much, Anjali. So we'll open this up to our audience. If anyone has a question, you can type it in the Q&A box, or you could also raise your hand. Hopefully I'll be able to see you, but I don't think I can. So if you have any question, please type it in the Q&A, and we'll make sure that Dr. Chirikas responds to it.
And Deos, while we're waiting for folks to write in the Q&A, can I ask a really quick follow-up question about
go ahead, Rebecca.
About just trying to your comment about figuring out like the actual costs. Is that with the intent to, is the thinking that right now some of these local partners or local governments are actually carrying a more of a, I don't want to say a burden of the cost, but trying to actually figure out how is the idea that those entities are going to actually then get credit for what they've already put into the program and how they are budgeting on a regular basis for services and continuation, or is it more that you think that there are hidden costs within the more on the PEPFAR side that you just haven't accounted for? I know it's a little weedy, but I'm just kind of curious where the thinking is on that.
Well, we're really trying to understand the full scope of the cost of all of this. I mean, to the point that Deos made, or maybe it was the Eswatini team, that as we think about sustainability, there are costs that we have incurred in the PEPFAR program that may not be essential, or that may not be able to be funded by local governments. Ultimately, we need to have more and more financial contribution from governments. And like I showed you on the one slide, we are seeing significant input from local governments into their own HIV response. So part of it is really trying to account for that, but also trying to extrapolate what our added costs might be that may not be able to be incurred by the governments themselves. And that's part of determining what is the more simplified, what's the next generation of some of our programming? What is the more simplified delivery of interventions that we can do? But a part of this too is also in a very deliberate exercise between Global Fund, PEPFAR, and the partner governments, the domestic resources as well, because there are these three funding streams coming together, and so we all work seamlessly together. So for example, it's not just with the government; it is with Global Fund. We do in certain countries, we do the service delivery, but Global Fund will pay for the commodities. And so then it is, okay, we need to make sure that those commodities come in, but then we're going to be adapting our service delivery model to make it more efficient so that the government can assume more costs into the future.
Thank you. We have a question, from Dr. Martine Meshubi. She says that your slide on the economic impact of COVID was in countries with high HIV prevalence was revealing, and she would like to know if she would like to see what the uptake of or availability of vaccines are in those countries. Have you looked at any preliminary data on this? In other words, have you been looking at the uptake of vaccines in countries with high HIV prevalence or HIV burden?
So thanks for that question, Martine. We are looking at that. I don't have those data on me at the moment, but we are looking to see to look just as you've described here, to really try to understand what is happening specifically with vaccine uptake, availability, coverage in these countries that have the worst HIV rates as well. So more to come. One of the things that I am excited about, we have all of our data transparently available on our website. So I mentioned all those 70,000 sites and age and sex disaggregated data. That's all on our website. One of the things we've recently added is some data on COVID in all the countries the 55 countries that we support. So so take a look at our website. We're starting to add more COVID-19 data there so that you can see it all triangulated together. But great question, and more to come on that.
Thank you. We are waiting for more questions. In the meantime, Anjali, I would like to follow up on what you said about transitioning service delivery to local partners and how that in many ways has obviously helped with some of the cost savings. One comment I tend to get from governments over the years is that while PEPFAR has done a fantastic job, bringing resources into local organizations, there is a criticism that, a huge number of these local organizations are actually new, have been largely started through PEPFAR funding or PEPFAR support. They don't have any other revenue sources besides HIV. And therefore, if, knowing that PEPFAR funding always comes through a competitive process, if they lose the next funding opportunity, then they are likely to close. And that means the capacity build goes from that organization. But secondly, from the government perspective, the criticism is that, PEPFAR is moving resources from international partners and basically creating, these local organizations. So it's like replacing Georgetown with the Georgetown local, if there was such. But that capacity is really not necessarily so much integrated within the country's public health system that is largely run by, government, services, faith services, or faith-based services, or the private sector, because those are the three really that own and run health facilities, while these local partners that are funded are really, standalone institutions that come in, to provide technical support to the existing public health system. So what do you say to that criticism that we are creating organizations that may not be sustainable, and hence that local capacity created may not last for a long time? And that besides, this kind of is creating a parallel structure to the existing public health system in the country.
Thanks for that question. And, we're learning as we go, right? We're learning, and so these inputs and questions are really helpful for us. One of the things that I think is important and that we've been trying to do, and maybe we need to kind of double down on this, is, what we've been trying to do is not just build the capacity of local organizations or local capacities to deliver HIV services only, but we've been working with them on organizational capacity as well, financial management, knowledge management, these things that are essential for any organization to not just get resources from PEPFAR, but be able to manage and get resources from other entities as well. We have examples in parts of Asia where they are farther along in some ways, where we've been working with local partners in some of these organizational capacities for some time, even some really, really local community organizations. And we've been working, we have examples in Thailand with like an accreditation type system that is in place, where some of these community organizations are actually being recognized officially by their respective governments. And so there's funding, they're able to get funding for the first time through their government. So we're trying to do, we're trying to make sure that these, I would say that not every example is sort of those big examples that you see of the spin-offs of the big implementing partners from the US that then have local partners. There's a lot of local community, very local organizations that we're also trying to work with to build those broader organizational capacities as well. But like I said, we're a learning institution. I'm sure we're not doing it. There are better ways that we can be doing it, and we're always open to learning from experience and input to try and get better. Because I do think it is going to be important for all of us as we move into the future with local implementation. The value of that is really extraordinary, and we need that moving into the future.
Thank you. We have another question from Sanjana Mukherjee, and the question goes, from a regulatory standpoint, and with the African Medicines Agency Treaty being ratified recently, do you see PEPFAR considering moving resources towards supporting the African Medicines Agency for regulatory approval of ARVs, rather than relying on FDA for regulatory approval?
That's a really great question, Sanjana, and thank you for that. This is all very recent, and we're beginning to explore, what this could look like for PEPFAR, for ARVs, et cetera. We have not yet made any determinations in any way. But it's something that we're, again, we're exploring all of this as we think about the future.
Thank you. Any more questions? We seem to be running out of questions. We still have,
it's quite early in the morning. It's a lot to ask everybody. And I should also note that I believe Anjali is coming straight off of a overnight flight. I don't know how many hours of sleep she's had, so we're extraordinarily thankful for being able to do this. Yeah, Deus, I don't know if you have a last thought or a question, or maybe we can turn it back to Anjali for kind of a final thought before we wrap up.
So really just only to thank Anjali for shedding light on these issues. I am in that PEPFAR community, so I look forward, Anjali, to continuing some of these discussions. We've been speaking with some of your colleagues, Mike in particular, trying to think through some of these sustainability issues. So we look forward to continuing, the engagement. But at this point, I'll turn it over to you for the last final thoughts you may have. Thank you.
And even before that, I'm just going to say we're going to keep pinging you on the AMA question. It's I think a really fascinating issue, and as we look at the development of these of new regional organizations and what that capacity looks like, and some of the legal and regulatory questions are of great interest to us. So we might follow up with you on that and see where this goes.
No, please do. Please do. I mean, look, it gets back to the very first point, Deus, that you made. Public health is now mainstreamed in many ways, right? And so this is an opportunity, I think, for all of us to continue to explore and look for new ways of working better to sustain this work that we're doing for the future. Again, for HIV, I guess I'll say this in my closing remarks, as I said earlier, it really is this unprecedented state that we're in, right? With countries getting at epidemic control or getting to epidemic control. And that the very future then of what sustaining epidemic control of HIV looks like really has many of the same elements that would be required for other health threats. And so it behooves us all to be thinking about whether it's the AMA question that Sanjana had, or Rebecca, you're going to keep pinging us on, or whether it's more of these integrated services, Deus, that we talked about earlier, or whether it's, what are the actual costs and how does that translate, how into more simplified services that are able to be afforded by the countries themselves. These are all questions and answers that we're going to have to continue to delve into together as a global community, because what we're doing with HIV through PEPFAR, yes, it's extraordinary and it's a global community that's a part of it, but now that this body of work that we've been doing with PEPFAR relates in this broader environment, this broader global health, environment that we've seen so clearly with COVID-19, and as we think about the future of health security. And so, I'm just grateful for this opportunity. I'm grateful for further discussions that we'll be having, because as I said, we're all going to be asking and answering questions together as we evolve to the next state that we'll all be in as we think about global health and global public health more broadly. So again, thank you for this opportunity, and I'll look forward to staying in touch with all of you.
Thank you.
Thank you very much.
Thank you so much for doing this morning. We will let you all run off to actually start your days, because it's approaching 9 a.m. here in Washington, D.C. But really thank you for joining us, for being part of this conversation. Deus, thank you for leading us in discussion and bringing all of your experience and expertise as a PEPFAR implementer to this conversation. So again, thank you again, and everybody should have a wonderful day.